I am Chen, the Program Coordinator for KES Malaysia. Thank you for joining us. Welcome to the first of a series of webinar that will talk about the concept of the social market economy in the context of what is happening now in Malaysia. In this case, it's the healthcare system of Malaysia. Firstly, a quick thank you to all the speakers, Dato Professor Dr. Adeeba Kamarulzaman, Dr. Michael Jeyakumar Devaraj, Professor Dr. Geoffrey Williams, and the moderator, Dr. Khor, Swee, for accepting our invitation to speak. As there are a lot more important things to discuss, let me quickly introduce you to Mrs. Miriam Fisher, the Country Director of KAS Malaysia. Before her appointment as the head of the Malaysian office last year, she has worked in KAS for development projects in the offices of Brussels, Manila, and for Sub-Sahara projects in the headquarters in Berlin. Miriam, over to you.
Thank you so much, Chen, and good morning and a very warm welcome to all of you. My name is Miriam Fisher. I am the Country Director of Konrad-Adenauer-Stiftung, or KAS, in Malaysia. I would like to welcome everyone in the audience, and I would also like to extend a very warm welcome to our wonderful panel of speakers today. Today marks the first of our webinar series on social market economy perspectives. And we chose healthcare as the topic of our kickoff event. And now you might wonder, why on earth did we decide to take on one of the most difficult discussions for the very first session? And you would clearly have a very good point wondering about that. So it is indeed a difficult topic. The German Chancellor, Angela Merkel, in fact, actually once said that she does not know of any other political field that is as hotly debated as the healthcare system. And she's right. Healthcare is certainly a very sensitive area. It links to people's worries, to their concerns, their feeling of safety. And especially with the current pandemic, social protection and healthcare are on everyone's minds at the moment. KAS bases its work on a very simple principle. The human being and its dignity must be at the very center of every policy decision. For our discussion today, I would like to remind all of us very much about this deeply rooted conviction of ours. One of the most difficult political tasks is to set the framework conditions for the healthcare system. It is an everlasting, continuous challenge of health policy. And transparency, as well as an objective public discussion, can very much help in this. Now, doctors must act in the best interest of the patient. And as I'm sure we all agree, most of them, the big majority of them do. But medical care is becoming increasingly profit-oriented. And it is therefore very important that such developments are openly discussed and questioned in public. And that is why we all joined here today for an open discussion about healthcare. And I'm very glad to have such a wonderful panel of experts with us today. I wish us all a very interesting and healthy discussion. And it is with that I would like to hand over to our moderator today, Dr. Khor Swee. Dr. Khor is a Malaysian physician specializing in health policies and global health, and he holds fellowships in Chatham House, the United Nations University, as well as ISIS Malaysia. And he has worked as a doctor, as a refugee doctor, and in the pharma anti-corruption sector. And he has actually covered more than 90 countries around the world in that. He holds postgraduate degrees in international medicine, public health, and public policy. Dr. Khor, thank you so much for being with us today. The screen is yours.
Miriam, thank you very much, and guten Tag to everyone. I thought to begin with a bit of German because this is organized by the Konrad-Adenauer-Stiftung. So thank you very much to the Konrad-Adenauer-Stiftung. I'm pleased to moderate today's session. So as my introductory remarks before I introduce the panelists, allow me to sketch a little bit of the agenda for today and then make some introductory remarks. Firstly, this will be a session where we will hear from 3 experts, and we'll hear from them over the next hour, and there will be an opportunity for questions and answers at the top of the hour around 12 p.m. Malaysia time. So if you have any questions, you can type them into the Facebook page of Konrad-Adenauer-Stiftung, or you can put it into the chat function in Zoom. The second element I wanted to share with everyone today is that if possible, please keep on your camera so that we can have a more interactive session. This will be a session that we hope that everybody will feel very free to contribute their thoughts and their opinions about how to strengthen healthcare in Malaysia. Those are the house rules for the next 2 hours. Allow me to make some introductory remarks at the moment, maybe in 3 sections. The first section is to talk about how health is a form of social accounting. What I mean to say is the health of a population indicates the success of government policies, not only in health, healthcare, social protection, the economy, and how we interact with every human being in the welfare of and the dignity of their their lives on a daily basis. So when somebody lives a long life and it's a healthy life, it's actually a success of all sorts of government policies, not only government policies in the Ministry of Health. Therefore, we move on to the second set of comments that COVID is providing an opportunity for Malaysia to strengthen our system or to reform our system or to improve our system. Malaysia's healthcare system or health system is very large. Some parts we can improve over time. Some parts need dramatic reform. But when reforming the healthcare system of Malaysia, we must also consider the role of the private sector. And this is my third set of introductory remarks, that reforms of Malaysia's health system cannot only be limited to the Ministry of Health. It must also consider the right role of the private sector. This means that the economic agencies like the Economic Planning Unit, Ministry of Finance, the Central Bank of Malaysia, these economic agencies, the trade agencies, and the central planning functions will all be involved in the reforms or the strengthening of Malaysia's healthcare system. So I look forward to this conversation where we'll hear views from our experts who are, some of them are clinicians and some of them are economists, and they will tell us what it means to reform or strengthen the system in ways that are not only within the Ministry of Health, but also outside the Ministry of Health. Ladies and gentlemen, I'll end with the topic for today's webinar to refresh everyone's mind again. This is a discussion today about the right role of the public and private sectors. And built into that conversation will be questions like, what is the right role of the private sector? Should we even be allowing the private sector to make profit? What's a reasonable profit? And how do we regulate the private sector so that we can achieve at least 3 outcomes? And I hope that we can bear this in mind. The first outcome is equity. The second outcome would be efficiency. And the third outcome will be quality. Or to put in different words, how can we give high quality healthcare to 32 million people in Malaysia with high access at low cost in a way that combines the public and private sector? So with that in mind, ladies and gentlemen, let me introduce our first speaker, who is Professor Dato Dr. Adeeba Kamarulzaman. She needs no introduction, so very happy to have Prof. Adeeba here. Most recently, she was the Dean of the Faculty of Medicine at University Malaya for, I think, 9 years, Prof. Adeeba, and most recently was elected to the Science Council of the World Health Organization, a very high honor. She's mostly known for her work in HIV/AIDS and infectious diseases, but also in terms of her advocacy for health reforms in Malaysia. Prof. Adeeba, we're delighted to have you. The floor and the screen is yours right now, Prof. Adeeba, for you to share your thoughts on 2 broad topics. How do you view the current landscape of how healthcare is organized in Malaysia in terms of equity, efficiency, as well as outcomes or quality? And what are your recommendations for how we can improve or strengthen the system? Prof. Adeeba, we're delighted to listen to you.
Thanks very much, Swee, and thank you to KS for inviting me to join the other distinguished panelists this morning to share my thoughts on Malaysia's current health system and the way forward. I think before I specifically answer your first question in terms of what are my views of the current way we organize our health system into public and private, I think it's worth looking at the current landscape and the current trends of diseases in Malaysia. Of course, we all know that we have an aging population that I dare say we probably are not well equipped currently to deal with this problem in terms of aged care. So, the population is getting older, but are we getting older in a healthy way is also a key issue. Are we getting older with, more strokes, more, cardiac disease that requires a higher utilization of healthcare? So that's number one. Number two, in terms of the trend, is of course the disease burden. it's very well known that Malaysia has very, very high prevalence of diabetes and obesity and other non-communicable diseases, which also we need to deal with in more efficient and with more quality care, I think, particularly in terms of prevention. And although we thought we had outsmarted and I was going to run out of work as an infectious disease specialist, then came COVID. And I think, excuse me, if nothing else, I think COVID highlights the importance of a public healthcare system, a good quality public healthcare system, which I'll get back to. The third is in terms of changing trends and how it will impact on our healthcare system is the urbanization and movement towards people living in cities and growing middle class who have very high expectation of healthcare delivery systems. But at the same time, we have an increasing inequality gap in our country. So, the haves have access to the private system, but what about the have-nots? Are we catering enough to them, particularly those in rural areas and in Sabah and Sarawak? The fourth bit, which is something that's very close to my heart, is of course the healthcare workforce. This is a perennial problem. Not just in terms of doctors and specialists, but nursing. I think we face acute shortage of nurses, and also the allied health professionals can be better developed. Physiotherapists, occupational therapists, to play a much bigger role in the whole ecosystem than they are currently, particularly when we look at the changing trends in terms of demographics and diseases. And then finally, of course, increasing medical costs. The medicine becomes more and more sophisticated. We're talking about precision medicine. We're talking about application of genomics in diagnostics, in treatment, in disease surveillance. All this, of course, comes at increased costs. So with all that in mind, do we have a health system that is fit for purpose? I think, speaking, you like that phrase very much, fit for purpose. We know very much that, we can proudly say that for the most part, 80% of Malaysians have access to some form of healthcare, particularly in Peninsular Malaysia. But, in Sabah and Sarawak, I think that number drops down quite significantly if we're looking at access within 45 minutes to healthcare, and especially to more sophisticated healthcare. So that's in terms of access. And we know the other big issue in terms of this private and public dichotomy is that for specialists, excuse me, something like 70% of specialists are providing care for 30% of the population. And excuse me, as a trainer of not just medical graduates, but also postgraduate, we can't seem to produce specialists quickly enough for consumption for both the public and private health system. As soon as we train them up, we lose them to the private system. And so that's a constant source of frustration for all of us, still working to ensure that we have a robust and a strong public health system. And then, of course, the issue of cost. And I think what Miriam started off in her introduction, philosophically, do we have a healthcare system that is increasingly geared towards profit versus, its true role as providing care for Malaysians. So, my concern with the increased privatization of healthcare are several folds. Number one, I think going back to this 1 year experience of COVID, we need a strong public health system, full stop, whether it's in delivering public health in its true form, in terms of prevention health, in terms of disease surveillance and on all the activities related to this outbreak. No private health system in their right mind would be willing to do this. And I think if we don't learn from this COVID pandemic and invest in our public healthcare system, we haven't learned an important lesson from the pandemic. I mean, we just have to look. Hopefully we don't get to the level of India, although our numbers are increasing. But I recently read a commentary, that kind of, maybe putting the blame is too harsh a term, but because of the increasing privatization of the Indian healthcare system, the public health has been severely underinvested, and they've not been able to cope with the current crises that they're facing. And although we're not to that level, I think it is a very, very important lesson that we need to learn from this pandemic, that we need, and I stress again, to strengthen our public health system. Who are the people currently providing the services to overcome this pandemic, whether it's in the public health interventions, in prevention, or even in providing direct care of patients with COVID-19. So that's in terms of COVID-19 and infectious diseases. But even with, in terms of the burden of disease with the aged population and communicable diseases, where the focus needs to be in terms of prevention health and also, taking care of the elderly. Private health system is not. When I think when we talk about private health system, we think about hospitals, we think about acute care. Where there is a role for the private health system is, I think, in strengthening general practitioners to be part of the ecosystem to provide preventive care as well as aged care. So I think that role is very important in addition to the public health sector. Where I think there's been an imbalance is this, in acute hospitals, and perhaps too much resource, too much attention given to this private acute care hospitals in the hope of, medical tourism, etc., etc. Whereas I think we still have ample room to strengthen the public health care. My third concern in terms of the profit-oriented healthcare system with expansion of the private sector is, of course, as I alluded to, is the brain drain, the internal brain drain from the public health sector to the private health sector. In addition to having inadequate number of specialists to provide care for 70% of the population, both in the teaching and in Ministry of Health hospitals, when we have this brain drain, we are, what's the word I'm looking for? We are losing senior staff, experienced staff, for the training of future doctors and specialists. And I think, in my years as dean and still practicing, this is one of the serious, perhaps not very, it's not highlighted enough of how important this is in terms of ensuring the quality of doctors and specialists in the future. That whole ecosystem, it's not just about it's not just about retaining quality and experienced staff in the public system to deliver services, but in terms of training future generations of doctors. So I think you can guess where I lean towards in terms of the public versus private health system. There is, of course, a role for private healthcare, but in its current state, there is no doubt that there has to be a bigger investment in the public system and to strengthen them, because there are many things that we can improve on, such as preventive healthcare, public healthcare, and all these things, and aged care, community-based care, which are not so sexy for the private health system. They probably, particularly public health in its true sense, as well as preventive care, probably doesn't bring in terms of ROI, as acute care hospitals do. So those are my initial thoughts in terms of why I think, yes, there is a role for the private health system, but there needs to be a much bigger investment in the public health system for all those reasons that I just listed. And in terms of the way forward, I would like to hear more from the other panelists. But I think, obviously, the current budgetary allocation to the public health system is just simply not enough. Although, we can pride ourselves for the amount of money we get, by and large, we're getting, most of our rakyats getting good quality care. But I think if we're going to join the likes of developed nations, then at least another 3 to 4% increase in the GDP budgetary allocation to the public health system is required, because I can list down a whole load of things in terms of the shortcomings in the public health system. I think many of you are familiar with it already. So the question is, how do we do that? Is it from direct taxation? Is it from having a separate, health financing system? That's not in my area of expertise, but certainly, greater investment in public health and greater allocation is needed. The second thing, as I said, that's very close to my heart is in ensuring a better health system is, I think, a reform in how we train our doctors. Again, Swee King, you're very familiar with some of the work I'm trying to do. And I think there are many things that we can do to increase not just the quality, but also the quantity of specialists that we train. And similarly with nurses, we desperately need to improve the numbers of nursing staff and also the number of the quality of nursing staff in this country. They as a profession, they kind of haven't parallel the doctors and the specialists in terms of having specialist nurses like many of us are used to when we work overseas. And of course, in terms of the nursing profession, I think a serious look at their salary packages. It's so far less attractive, particularly in the public system. I mean, I'm just told that we've just had 10 people resign, nurses resign today as we try today or this week or this month as we try to open more ICU beds for COVID. Many, of course we can't compete with, the Gulf states, but many leave to work in the Gulf states or even to Singapore because of the huge disparity in their salary packages. And then thirdly, like what I said at the beginning, I think we need to also focus more on the role of health. Sorry, the thing just muted itself. We need to focus more on the role of allied health professionals, particularly as we hopefully move towards community-based care for the elderly and those with non-communicable diseases, whether it's physiotherapists or occupational therapists, and also for pharmacists to play a bigger role so that they can take some of the burden from doctors in terms of delivering care. So perhaps, speaking, I can stop there in terms of my early thoughts on the current state of the healthcare system and some big picture big picture. Thank you.
Thank you, Prof. Adeeba. That was excellent. And you've given us some big picture trends of where healthcare is moving. You've also spoke about your concerns about the, shall we say, privatization of healthcare, especially if it's uncontrolled. And you've spoken a lot about some solutions for the future, especially about, say, the areas that private healthcare hasn't really gone into in Malaysia, and also its impact on human capital and the brain drain. Thank you very much, Prof. Adeeba. The next speaker that we have is actually Dr. Michael Jeyakumar Devaraj, or Dr. Kumar as he prefers to be known. Dr. Kumar is also needing no introduction, but a brief introduction to him is that he's a respiratory physician turned an activist and a very well-informed commentator on the state of health policies in Malaysia. He's also a two-term member of Parliament for the Sungai Siput constituency in Perak, and these days he is also the president of Parti Sosialis Malaysia. Dr. Kumar, who's published and written quite a lot about the dichotomy of public-private healthcare in Malaysia, and also a lot of recommendations of how to strengthen the system. It's a pleasure to have you here, Dr. Kumar. The floor is yours for the next 20 minutes to take us through your thoughts about the landscape of healthcare public-private in Malaysia, on equity, efficiency, and quality, and how we can strengthen the system, both public and private, to get there. Dr. Kumar, over to you.
Thank you, Dr. Khor, and thank you to KAS for inviting me. Actually, the topic given to me, the overview was, should Malaysia move to a healthcare system provided by private companies, funded by an insurance scheme, where the government acts only as regulator? And that's the, can I have my slides, please? Yeah, so that is the topic given. And I was a bit surprised that I was asked, the next slide, please, that I was asked to comment on this, because I think it's quite well known that I am quite against the idea of marketizing, making the market very prominent in the delivery of healthcare. You know, I think in Germany and some of the European countries, they have a fairly good social insurance scheme that has been set up, and it's working quite well. It's quite equitable. But we have to remember that those schemes came up at about 100 years ago, you know, at the turn of the century, when there were very strong working class movements, social democratic parties and communist parties, and they're pushing for the rights of workers. So these schemes came up in that time, and they were shaped by the historical circumstances of that time. And the situation in Malaysia now, in many parts of the world, where we are much more into a neoliberal stage, where the influence of workers and of workers' organizations like unions is much, much less than they were in Germany and in France, in those countries which are using health insurance when it was actually set up. So actually, I think this idea of provided by private companies, funded by insurance scheme, and government as only as a regulator is a very bad idea for Malaysia. Next slide, please. One reason why this is bad, next slide, please. Then one reason why it's bad is, if you look at our current budget and our current private healthcare, we are spending about, the government, the MOH spot budget for this year is about 32 billion. The private is, what's spent in the private side is also about equal. We're spending altogether about 4% of GDP, half by the government and half is in the private sector by people. Look at the admissions. This is the figures for 2017. That's the latest I could get. You know, it's more or less like that, maybe even more MOH now, percentage-wise, than private. So you can see about 70% of admissions of inpatients are to MOH hospitals. So you can, so if that means the MOH budget is not only for inpatients, also for outpatients, also for preventive care and all that. But roughly you can see that inpatient care is about 50% the cost per patient compared to when it's done by the private sector, right? You're looking at 70% of inpatient patients in MOH and 30% in private. The total budget, both sides, about 32 billion. Now, if you were to bring it all under private, let's say we don't have any more MOH, let's say we just have all private, and they have the same level of charging, patients. Can I have the next slide? You would have a total budget. Can I have the next slide, please? You'll have a total budget of 96 billion, 32 for the whole population. 32 is only for about 1/3. And you divide this by 32 million population, right? 26 billion per year, you divide by 32 million population. The cost actually would be 3,000 per capita per year. For a family of 4, it will mean $12,000 per year per family of 4, or roughly 1,000 per month. Yeah. Now, this is not possible. I mean, to say that you're going to have the government reduce only to regulator, no way. The government is going to come in and subsidize healthcare. No way in which the Malaysian government can pull out of subsidizing, paying for healthcare. Next slide, please. See, if you look at Malaysian household income, our 20th centile is about 3,000. This is for monthly household income for a family. 3,000 and below, about 20%. Between 3,000 to 4,003 is another 20%. Between 4,3 to 9,6 is about the M40, another 40%. And only 20% of the population of families earn more than 9,600. So this is the picture in Malaysia, in terms of the, next slide, please. So if you look at that, there actually is what I would call wage suppression in Malaysia, okay? Where the wages, what people earn, is far below the living wage. You look at Bank Negara, they come out with figures saying that a family of 4 would need about $6,000 to survive in KL, But our median wage in the manufacturing sector, median wage is 1,007. The median wage in other sectors are probably lower. Maybe construction is slightly above, but other sectors like plantations, service sectors is about that as well. Our minimum wage in Malaysia now is 1,002. The minimum wage in Germany is 7,800 ringgit, if you convert it. So this is not, see, World Bank and IMF will say, oh, your productivity is low. That is a lie. That is not the real reason. There is wage suppression. The way in which the economic system is structured makes it difficult for us to raise wages. And like I tell my party members, we cannot blame individual businessmen or individual factory owners and say that and attribute low wages in Malaysia just to the greed of our local businessmen. It is not. You see, if I was a factory owner producing shoes in Malaysia, I have to be mindful that in ASEAN, with the free trade area, shoes from Vietnam can be brought and sold in Malaysia with hardly any tariffs. So if I raise my wages and I raise the price of my shoes, I will lose market share to the Vietnamese shoe manufacturer. So it's not that I am greedy and I'm very hard-hearted. But if I was too soft-hearted and raised the wages of my workers too much, I would lose market share. I have to close down. So that is what I mean by wage suppression. The system in which we are locked into, we are stuck into a low wage economy. Nothing to do with productivity. So when you have that kind of situation when we cannot pay our workers a fair wage, then we have to look at other ways in which we can give them a social wage. We can give them subsidized healthcare. We can give them subsidized education. We can subsidize public transport. That's another way in which we can share the wealth of our country. So we would be very much against saying, oh, healthcare is expensive, let the workers pay for it, let the population pay for it. Because we are not paying population, our people, enough. We're not paying them a fair wage because of this wage suppression thing. So that's why I think to say government no longer provides the money, no longer provides the healthcare, give it all to the private sector, let the people pay for it through insurance, wrong way to go for Malaysia. Not yet time. We've got to solve this problem of wage suppression first. Next slide, please. Next slide. So now, if you move on to, if let's say the government subsidizes, we have insurance, but the government subsidizes for the bottom 40%, it'll be a huge subsidy. It's 38 billion, more than what the government's already paying. And what about preventive healthcare? And what about healthcare for government servants and pensioners? It won't save money. This system will not save money for the government. It'll probably be more expensive, and you won't get the service you're getting now anyway. So if you go on to the next slide, please. You see, there is in some quarters a naive belief in markets. The feeling is markets are very efficient. There's the best way of allocating resources. But when you go to a privatized healthcare system and you start paying fee for services, costs just escalate. It is common, it's common knowledge in the private sector. If you go in and you're paying out of pocket, the charges levied against you would be lower than a person comes in with the insurance. A person with a third-party payer would get higher charges, would get more investigations, would get more treatments than a person who's paying out of pocket. That's the reality, this is how people work. And even if you say, okay, we're going to go into these DRGs, disease-related groups, you'll pay the hospital, we won't pay the doctor. If I was a hospital administrator, right, and I earn money from how I charge the government this insurance fund, I would prefer that to be more appendectomies. If my surgeons are so smart to pick up mesenteric adenitis and don't operate, how much can I charge for mesenteric adenitis? I can charge more for appendix. I can charge more for a Caesar than a vaginal delivery. So there are certain perversities that will occur if you go into a system where you marketize it. Where, see, right now, we give global budgets to our government hospitals. Yeah, this is your amount. Based on what you got last year, we're giving you a 5% increase. You manage everything within that. So the treatment then the treatment given is not based on how much money I'm going to get from it. But if you have an insurance scheme that pays fees for service, that you do this kind of services, this kind of operations, this kind of treatment, this kind of scopes, we pay you for that, there'll be an escalation of scopes when you don't need it. See, medicine is not an exact science. There's a lot of gray areas. When a guy comes with chest pain, you just take the history, do a stress test, and say, "Don't worry, you don't have, doesn't look like it." Or you go and do an angiogram. That is a gray area. It's not something which is hard. So when you have put in an economic incentive into it, you're going to shift all treatment, all investigation more to the expensive side, as either individual doctors or institutions try and earn money. It's going to blow your budget. And we're going to pay the whole medical system on treatment, then you're moving away from prevention, moving away from health prevention. That's the wrong way to go for Malaysia, really, in terms of cost, in terms of the focus, in terms of over-treatment, So that is another reason, yeah? Now, can I go to the next one, please? The other thing is people who want to marketize things and make people pay, it's basically a misconception of human nature. It's this concept that Homo economicus. That people are only motivated by money. It's true, people like money. People need money, but that's not the only motivation. We know, like in our healthcare system, our public healthcare system in our universities, people are not paid by what they do. They're paid, they got their duties, but they're not paid by how many operations or how many stress tests or how many scopes. They're not paid like that. But people still work hard. Many of my friends in government service work hard. The other incentives, people, I think, get satisfaction in delivering service, in being good, in getting the diagnosis, in being recognized, in doing the job well. So these are other incentives as well. So we don't need to go only on economic incentives. But if we use economic incentives, if tied into fees for service, that also changes behavior. It does. And in perverse ways, like I said before. Now I think we need to take into account, next slide, please. Next slide. There is a pecking order in the world, okay? There is a pecking order. And we are not the bluebird. The bluebird probably is America. The second tier is the EU. We are probably the third level, getting a bit shat on, but we're not as bad as the fourth level, the fourth world. The thing is, our options when we are here is that we have a lot of problems. Like, for example, we can't raise wages because we are locked into a low income economy. We are locked into low taxes because we are all fighting for FDI. Our corporate tax now is for 24%. It was 40% in 1988. We've cut it down to 24%. Singapore is at 18%. We want to maybe cut it down further to get FDI. Because it's important, taxes are important, because they cut down taxes. Then your budget is not big enough to expand healthcare, like Professor Adeeba talked about. We need more money in our public healthcare system. I agree, totally agree with that. But we cannot look away from the fact that we are in this pecking order and we are in competition with our ASEAN neighbors for FDI. We need FDI because then we have investment, then we have jobs. So if they cut taxes further, we are also obliged to cut taxes further. So this is something we've got to remember, that this problem that where we are and the FTAs that we get into that solidifies, that enhances this pecking order and keeps us in our place. For example, the ISDS, what investor state dispute settlement, where the investors from the bluebird upstairs can come and drag us to a tribunal in New York, where they can bypass our local courts when they have a dispute with the government regarding any economic changes that we bring. These are the facts that we have. You can't say we're only talking about health. Health is linked, public health is linked to how much funds we can get from the government. And how much funds we can get from the government is also dependent on the whole system within which Malaysia finds itself. And we are on the third tier. So there's certain limitations, that we face in Malaysia. So can I go to the next slide? See, this basically talks about the minimum wage in Germany. It's 1,584 euros. You times it by the exchange rate, $4.95 to the euro, it gets 7,800. Malaysia, the minimum wage is 1,002. Okay, cost of living in Germany is maybe 2.5, 3 times higher than Malaysia. Okay, but if we divide 7,800 by 3, the actual real income of Germany's workers is about 2.5 times, 3 times ours, you see. So to talk about having a tax on them, a GST on them, or to talk about them contributing to an insurance, it does make sense because they get a higher wage, higher real income. Our income is really, really down and we can't push it up too much. Even if a left progressive government were to come in, we would have to be very careful that we don't spook investors, that we don't undermine our local producers of textiles, of shoes, or whatever they produce and sell to local market. If we push them, raise wages too high, they will lose market share and you'll have unemployment. These are real issues that we would have to work with other ASEAN countries, renegotiate the ASEAN free trade, talk about bringing up minimum wage in stages in all the different countries. Talk about stopping the race to the bottom by putting in barriers to lowering corporate tax any further. These are things we have to do. It'll take time. And until that is done, we cannot have enough money all the way. So we need to. So I think we got to talk about incremental changes. We have a system which is publicly funded. We got to think of how we can incrementally fund it a bit more and improve it. Now, so I would be against any grand scheme to revamp the Malaysian care system and bring it like the Germany type social insurance and all completely privately provided and the government only regulator. I think that would be a real disaster. It won't fit into us. Next one, please. So such a scheme, more efficient? No, it'll be more expensive, like I explained. More fair? Go to the next one, please. Go to the next slide to answer the more fair. Now, this is a quotation from a guy called Julian Tudor-Hart. He's a doctor in the UK, and I think he's passed away. And he says this is the inverse care law. It says the availability of good medical care tends to vary inversely with the need for it in the populations served. This operates more completely where medical care is most exposed to market forces, and less so where such exposure is reduced. It's quite clear. So if you marketize the whole economy or the whole economy of healthcare, it's not good for the poor. As by the inverse care law says that. I think it's quite true, this law. Go back one, please. Go back one, please. Does it improve the quality of care? No, I don't think so. It's going to lead to more intervention. It's going to be some kind of fee for service. Either doctors or institutions are going to do more and to earn, so they can cross subsidize the patients who are more ill. You go by the DRT system. Who would benefit? The private hospitals, right, will benefit. Private doctors will benefit. The crony GLC that gets to run this healthcare scheme will benefit a hell of a lot. Hell of a lot. I mean, look at what's happening in Malaysia. Are you going to create 100 billion fund and give it to some company to handle? It's probably going to be privatized to some company to handle, some GLC. Do we trust them? Do we trust it? Not yet, lah. We've got to build much more governance in Malaysia before we do all that kind of thing. Who would lose out? The ordinary man will lose out. We'll have to pay more for healthcare, and I think the poorer will get less healthcare. There will be a scheme. There may be top-ups. You have a basic scheme, and then you may have a top-up scheme. Guys with the top-up scheme will probably get more. I mean, it all depends how it works out. But these are what can happen. The other person, the other party will lose out as a government. Government will lose out because they'll end up having to subsidize a higher amount, but get back less than what it's getting now. Next one, please. It's already gone through that. Next one, please. Now, this is what I would argue for. This is what I like to see. We'd like an increase in funding for public health care. We are now at 32 billion. That's about 2%. We'd like this to go up to about 4% over the next 5 years. We continue with our global budgets. We could bring in the GPs. I think have a capitation system, bring in the GPs, let them handle non-communicable diseases. I think that can improve primary health care for diabetes, hypertension. I think that we have 7,000 GPs that they can be brought in and paid a capitation kind of system like the NHS to look after these patients, to improve our health care. We should increase primary health care, increase community care. Prof. Adeeba talked about nurses and physiotherapists visiting stroke patients, visiting OKU patients, visiting the children with special needs in the community. Yeah, so I'll write up now. Give me another 2 minutes. We can talk about decentralization of hospitals, not by privatizing them, government hospitals, but setting up regional trusts. Quality control through audits of outcome. How many of your infarcts died, how many of your gallbladder stones, infected stones died. those kinds of things, maternal mortality rate, it's worked very well. You don't need to have the market to have quality control. You can have audits by years. And very important, moratorium on new private hospitals. I think it would be unfair to close them down. But don't allow new private hospitals for the time being, because as Dr. Adeeba said, they augment brain drain, Our last slide. We have to remember where we are in the world pecking order. This is a real thing. It was set up since the colonial times. It hasn't really changed. We're not on the top level. We're the third tier. And as developing countries, we've got to talk about how we can renegotiate our position in the world global economy. It's something that not Malaysia can do alone. It's what we've done with other countries through WTO, through the WHO, through the UN. But the terms under which many countries like Malaysia are integrated the world system isn't quite fair. And this fact is actually not accepted. In fact, it is hidden by institutions like World Bank, WTO, and IMF. And we're going to look at this as well. Okay, Dr. Khor, I'll stop here. Thank you.
Thank you, Dr. Kumar. You've taken us on a bit of a historical journey, political journey, geopolitical journey as well, ending with some recommendations for how you imagine we can appropriately utilize the private sector, for example, getting them to community care, mobilizing the general practitioners, and having clinical audits to ensure that there is no over-utilization, which is a problem inherent in any fee-for-service model in any part of the world, really. So thank you for that exposition, Dr. Kumar. For our final speaker, we have Professor Geoffrey Williams. He's currently with the Malaysia University of Science and Technology. But he's trained as an economist, and he's had a series of academic positions and also consulting positions in various universities. And I'm going to read off a list: London Business School, the University of Oxford, Nottingham, University Tunku Abdul Razak in Malaysia, Help Institute or Help University in Malaysia, and now the Malaysia University of Science and Technology, in addition to some private sector consulting work. Prof. Williams, we're very delighted to have you here today. Tell us your thoughts, Prof. Williams, about where Malaysia's healthcare landscape is today and your recommendations for improving or strengthening along the principles of the social market economy. Prof. Williams, over to you.
Okay, thanks a lot. I hope you can all hear me. I'm going to try to share my screen because I have one or two slides. I hope you can see this. Let me see if I can. Okay, can you, I hope you can all see that. Can you just confirm you can see it? Yes, good. Well, thank you very much. Thanks to KAS, thanks to the other speakers. Unfortunately, I missed a little bit of what Prof. Adeeba was saying because of mutation caused by closing down the sound caused by my cat, unfortunately, but the cat is now mildly sleeping somewhere else, so he's obviously quite bored. So, but I heard the first part of it. I heard all of what Michael was saying, and I think some of the things that I want to discuss are similar. But obviously, I'm going to look at it from a different perspective because mine is from the perspective of economics and management. So I want to very quickly look at some of the basic data, what we would call the stylized facts, which have been mentioned, I think, particularly by Michael's presentation. But I want to just point out some of the issues which are, to me, quite surprising, because coming from the United Kingdom, of course, where we have a national health service, which accounts for overwhelmingly I think it's 95% of all of the activity in the healthcare system in the United Kingdom is run by the National Health Service. And yet here in Malaysia, as we have seen just now, actually the public provision of health in Malaysia only accounts for about half of the activity in the system as a whole. And there is a huge amount of, in terms of resourcing at least, that is being directed into the private sector. So these are some of the data. This is for 2017, but it's pretty much the same now in the last few years. And what you can see there, that in the data in 2017, the health ministry provided 43% of the resources available for the overall health system in Malaysia. Now, what you can see underneath that immediately is where is the balance coming from? Well, the balance is coming from your wallet, basically. It's coming from the rakyat. You're paying it yourself through out-of-pocket expenses. Out-of-pocket expenses account for 38% of all of the spending in the system. Now, to me, that was really quite a shock. But the second line, or sorry, the third line in that table was also, to me, quite surprising, which is the very low coverage and the very low percentage of total funding which is provided by private insurance. It's only about 7% of private insurance. And basically what this means is that half of everything that is being paid, half of the resources into the health system are being paid by private individuals. And most of this, as we'll see in a moment or two, is on an ad hoc basis. Now, I looked at this, what does this look like in per capita terms? And you can see that at the bottom. It's about 1,800 ringgit per person. But what I think is much more interesting is if you break that down per day. If you look at total health spending per person per day in Malaysia, it's less than the price of a cup of teh tarik. And half of that cup of teh tarik is being paid for by private individuals, out of pocket. And this, to me, is one indicator of some of the main problems that we see in the system as a whole. If we look at where this spending is going, which is the middle table, we can see that most of this spending is going on hospitals. That is, it's going on, and if you look at the table on the right-hand side, which looks at, it says curative and admin and public. Basically, this money is going on hospitals, and it's going to cure, or attempt to cure illnesses rather than to prevent illnesses. And I think Michael and Adeeba have both mentioned the importance of preventative medicine intervention and resources allocated to that. And what we can see very clearly from the data is that there isn't a great deal of money allocated or resources allocated to prevention. Another thing that is interesting to note about the private hospitals is that very often we tend to think of these as the 5-star hotels that we see often in the center of KL, often owned by GLCs, for example. But if we look at the number of beds available in the private sector, and we look at the number of hospitals, there are very many more private hospitals than there are public hospitals. And by and large, on average, these hospitals are very small. They're very small outfits. I mean, just where I live here in Sungai, we have a hospital just at the end of the street. And in England, we would call these cottage hospitals. And whilst we might often focus on the big 5-star medical tourism hospitals that we see, for example, in the center of KL, actually most of the private system is very small. It's being funded through ad hoc payments, out-of-pocket payments. And in many instances, it isn't fit for purpose because it doesn't have what economists would call the minimum efficient scale. So these are small hospitals with very limited service, run often by part-time consultants who are simply covering for that hospital and working in multiple organizations. And actually, because almost 50% of the system is being, the resources for the system are being focused on these small ad hoc organizations, just from a basic resource issue, it doesn't appear to be the most efficient use of the resources available. Now, if we also look at where the money is being spent, it's being spent on cures. That is, it's being spent on people who are already sick. It's not being spent so much on public health issues and preventative issues. But another issue that struck me from the data from Malaysia, which is very different to the data in the United Kingdom, is just how little money is available for long-term care for people with chronic illnesses, people with disabilities, and of course, increasingly, as we have demographic change, elderly people who need to have continuous care, often 24-hour care. And this type of activity is not funded. You can see there in the very bottom line on the table on the right-hand side at the bottom. You can see there that both in the public and the private sector, the amount of money, the resources available for long-term residential care is negligible. Negligible. In a society which is getting older, in a society where there is a very big need for this type of long-term care, and to me, what this tells me is that unless the doctors are curing you in a hospital, you are basically left by yourself. You are left alone to your own devices to find solutions yourself and pay for it out of pocket. And that, just on the basis of the stylized facts from the stylized facts and the resources available, these type of things indicate that there really is a need for some form of reform. What we need to understand very clearly from an economics perspective is the use of this term public good. Actually, healthcare is not a public good by definition in economics, because a public good is non-excludable and it's non-rival in consumption by definition. And healthcare clearly is excludable, and it clearly is rival in consumption. What that means is if I am using the hospital bed, you can't use the hospital bed. So actually, healthcare is what we call a merit good. It is a publicly provided private good. And the reason that there is an argument for it to be provided through the public sector is because if it were left to the market itself and to be provided through the private sector, you would get significant systemic under provision. Now, some people would say that this is a market failure, but actually, this is a consequence of the market working effectively. Because, unfortunately, the market, when left to deal with issues of efficiency and resource allocation, is actually quite good at dealing with efficiency in resource allocation, but it's not very good at dealing with equity. So unfortunately, if you apply the market mechanism because you want to have an efficient allocation of resources, what you would find as a consequence of that would be that very many people were excluded. Now, healthcare is one of the few areas of public policy which is subject to multiple market failure. Which we know about. We know about it both in theory and we know about it in practice through the experience all around the world from countries which have a very comprehensive, universal, publicly funded system like the United Kingdom, and compare that to a country like the United States where there is a very large private provision. And these forms of market failure are systemic and they are very difficult to solve through the market mechanism itself. And one of the main areas of market failure is the issue of information asymmetry, asymmetric information. And one element of that is the uninformed consumer. For a market to work effectively, you have to know what you're buying. And you have to know whether you need to have what you're buying. And you have to know whether there are alternatives to what is being offered to you. And you have to know what is the price of that and whether the price reflects the value of that. Now, in healthcare, when you go to see a doctor, you are already in a position of distress normally because you only go to see the doctor when you're ill. And in almost all circumstances, when the doctor gives you a diagnosis, you will not necessarily know whether or not you actually need to have the treatment that is being proposed to you, because you're uninformed. And what that means is that in the exchange, the market-based exchange, you would not be able to make a rational decision which would which would deliver the best outcome for you, because you have to rely on the seller of the service, in this case the doctor, which would be driven by the doctor's interests, not necessarily by the interests of the patient. And that is particularly true when the doctor's interests are also driven by a profit motive, as is the case in private health. And we generally see in private healthcare systems, we see overprescription of unnecessary medicines. We see overprescription of high-cost medicines. We see overprescriptions of forms of treatment, and particularly we see overprescription of interventional treatment, which is expensive. That would be an operation procedure, for example, by a surgeon, because that is expensive. And as looked at it the other way around, you would see under-provision of conservative treatments or preventative treatments, because conservative treatments and preventative treatments are not profitable. They provide less revenue. And this is one example of what we call a moral hazard. Now, normally we consider a moral hazard would arise on the part of the patient. You know, we normally say that if a patient is covered by a health insurance scheme, that might lead the patient to a more risky lifestyle. But actually, there is also a case, and I experience it here in Malaysia, which I believe is systemic, where if a patient is covered by an insurance scheme, there is a moral hazard on the part of the doctor, because the doctor then will have an incentive to prescribe expensive treatments or interventional treatments or surgical procedures, for example, because they know that the patient will be able to cover that through the insurance scheme. And that leads to a moral hazard in terms of the behavioral intervention between the patient and the doctor. So there is an imbalance, actually, in terms of the power relationship between the patient and the doctor. And in Malaysia, there is still, unfortunately, too much of this 19th century attitude that the doctor knows best. And the doctors themselves do actually have, unfortunately, they do actually have this attitude where they will rather forcefully explain to patients a need for interventions, particularly in the private sector, a need for interventions which may, if the patient went for a second opinion, which may not necessarily be needed. Now, you see this more often in the private sector because the doctors are driven by a profit motive. You see this less often in a public sector because in the public sector, the doctors are not driven by a profit motive. And therefore, they have no incentive to overprescribe. They have no incentive to recommend treatments which are not necessary. They certainly have less incentive to recommend interventional treatments and surgery if it's not necessary, because there's no financial reward for them to do that. So we see in systems of private medicine, systemic market failure for reasons that we know. And many of the outcomes, sorry, I just have to move my picture here. So some of the common outcomes that we see, which we can actually observe in the stylized facts of Malaysia, would be there's a denial of access. For example, people who are not able to pay for the medical treatment don't get access to the medical treatment. There is a focus on curative healthcare, that is, curing illnesses or prescribing medicines rather than to prevent. There's less of an emphasis on preventative medicines, for example. There is an under-provision of unprofitable healthcare. For example, long-term residential care, physiotherapy, for example, occupational therapy, for example, is very significantly under-provided because it's not profitable to provide these things. And we also get a reduction in the quality of services, and as a consequence of all of these things, there is a lack of a universal, comprehensive medical offering across the board if it is left to the private sector. Now, in Malaysia, of course, 50% of the overall system is being left to the private sector. And what that means is that for a very large number of people, these issues of denial of access, focus on curative healthcare, under-provision and lower quality, and a lack of universal comprehensive offerings is a commonplace experience. Now, if we look at this from a social market perspective, there are solutions to this. As an economist, basically, our initial response would be to say, when you have a question of resource allocation, you should leave it to the market. And in most other areas of economic activity, that's what we would do, and that's what we would recommend. But in the context of healthcare, because we have all of these systemic market failures, and I've only barely touched the tip of the iceberg in terms of market failure that's associated with healthcare when delivered in the private sector. But because we know that we have this systemic market failure, there is a prima facie, in fact, it goes beyond the prima facie case for public provision. It is compelling. There's a compelling argument for public provision. And I say that as a conservative. So from a completely opposite political perspective, for example, from Michael, completely the other side of the political spectrum, even those of us who are conservatives, who are market-oriented in our approach, who are economists, actually would recognize that the systemic market failure in private healthcare provides a compelling argument for there to be intervention. And this is one of the principles which is at the root of the social market economy, which is that markets left by themselves will fail unless there is a governance system, what's often called ordoliberalism, to intervene to deliver the market outcome as best as possible. And this involves important issues such as the principle of liability, principle of accountability, and the provision of merit goods by the public sector as part of an overall principle of solidarity, which is to say that we will, all of us, use health services. All of us will use health services at some point in our life, and as a consequence of that, there is a principle that we should provide it as much as possible through the public sector. I want to very quickly look at some management and leadership issues. I know I'm probably running out of time already, but let me look at some of the management and leadership issues which are extremely important. One observation that we would make from the perspective of management is the notion that most of the clinicians who make up the senior managers in healthcare institutions and in healthcare policy, most of the senior managers rather, who take up the senior positions in healthcare institutions and healthcare policy organizations, they are clinicians. And there are far too few people in senior positions in these organizations who come from a different perspective. In particular, there are far too few people who have formal management training. There are far too few people who have formal economic training. There are too many people within these leadership positions who are clinicians. What that means is that issues of resource allocation, management efficiency, and social balance are often overtaken by questions of clinical need, but they are also overtaken by some other systemic issues which cause management dysfunction in the system. One is the concept of an accidental manager. An accidental manager is, in this context, is basically a doctor who, in order to progress through their career, needs to take on, I know I'm running out of time. Yeah, okay, let me just try to finish. So the doctor would need to take on a management position in order to find career progression. And what that means is that you have people who are actually very highly qualified in medicine and very highly qualified as physicians, but they have no qualifications at all necessarily in management and leadership, but they have to take on these things because it's part of their career progression. We have very many other issues such as groupthink. They think in the same way and they make the same mistakes. That's a concept of groupidity. Many of these institutions are captured by people with similar interests or special interest groups. We have far too many grumpy old men within the senior management and leadership organization of the medical profession in Malaysia. There is a lack of diversity. There are too few people in terms of age, younger people. There are too few women. specialisms are not properly represented across the governance system, and also there is a question of aptitude for these positions. And another key failure of the management system is the lack of stakeholder inclusion. And this arises largely because of what we said in the first bullet point, which is that clinicians are taking over many of the senior management positions. So you don't have, for example, enough stakeholder representation, and particularly you don't have enough patient representation in the overall system in terms of helping to monitor resource allocation, quality, and the universality of the overall provision. Michael mentioned governance, and I quickly want to talk about governance because, and I'm going to finish it in a second, I understand. Okay, so Michael mentioned governance, and it's really very important. There are various statutory frameworks which help us to understand how the system could be regulated if the market were to fail.
Prof. Williams, if I may.
Yeah.
I'm so sorry, but if it's okay, out of respect for the many questions that we've received, perhaps just one more minute to wrap up the slide. Thank you.
Yes, so I'm going to talk about the governance issue. In order for a market to work effectively, in order for a market to work properly, it has to be properly governed. There has to be a clear regulatory system and a clear governance system. And there are various elements of legislation which we can perhaps discuss again during the question and answer. But amongst the biggest failure in terms of the regulation of the health system as a whole is the one at the bottom here, which is the Malaysian Medical Council itself. The Malaysian Medical Council is established in order to monitor and control the professional standards of medical practitioners according to the Medical Act, the regulations and the standing orders and various codes of conduct. So that is a key institution in terms of regulating the quality of the system as a whole. So I want to just, if I may, offer you a little insight into how the Medical Council behaves.
And we'll bring back Prof. Adeeba into the conversation so that we can hear more of her thoughts and also Dr. Kumar's thoughts as well, just to balance everything out. Prof. Adeeba, if I may just ask you the question from Scott Jordan that sent at 12:04 p.m. in the chat group, and I'd like to direct this question to you. Where is the greatest brain drain occurring from? Is it from public to private in Malaysia, from Malaysia to other countries? And what can we do to stem this brain drain? Over to you, Prof. Adeeba.
Sure. Thanks, King. Actually, the first level brain drain is from the public system to the private health system. You often see that, when they reach sort of mid-career level, then particularly those doing intervention specialties like surgery, or orthopedics, ONG, anesthesia, these are the popular ones, will resign and go to the private system. At the earlier stages, at one point, we would lose all our best graduates to Singapore when Singapore only had one medical school. Now that Singapore has a few themselves and are producing enough doctors or more than what they were, I think that has slowed down a bit, but not completely. So, yeah, it's both. At the early stages, our young graduates decide early on to go to Singapore particularly. One of the reasons for that is our training system. That it's a long wait to get into the training system. There's a whole list of issues and problems within the training system that needs to be addressed, much like what Jeff was saying, in order to attract more people, to kind of retain them. But the issue in public sector, the issue with the drainage from public to private is, of course, the the disparity in income. You know, someone who is 4 years out of specialist training can immediately earn 4 to 5 times what they would earn being staying back in the public health system. Honestly, when I was the dean, I used to wake up every morning and thank God that I still have staff working with me, because the gap is just so huge, you know, and especially for those who are the major breadwinners. And often when I do exit interviews with my colleagues, and this is in the setting that we have our own small private hospital at UMSC, you know, they cite wanting to give better education for their children, which means sending them to private schools. And what we're paying them in the public sector is not enough. And then, of course, and especially in a teaching hospital, they have to pay triple roles. They have to be doctors, they have to be teachers, and they have to do, you know, academic work and research. And so they say, well, stuff it, you know, I only have to be a doctor in a private hospital and earn 4, 5, name it, 6, 7, 8, 9, 10 times more. So yeah, it's you know, an everyday struggle to retain people.
Prof. Adeeba, to pursue a little bit further, it sounds that there are many reasons why people leave, and we probably need a basket of solutions as well to sort of keep people within the public sector within Malaysia. Do you have any ideas in your experience what might be most helpful that are either solutions within the Ministry of Health or outside the Ministry of Health?
Yeah, of course, money alone is not the motivator. I think some of the issues that Jeff touched on in terms of, you know, governance, in terms of, you know, empowerment, in terms of, you know, a more pleasant workplace environment, all those things play a role in keeping, in retaining people. But, you know, if you're constantly up against the system, whether it's, you know, your air conditioning doesn't work, or, you know, you're running out of medicine, or, you know, a whole host of other things as well on top of, or even, you know, many of us stay back in the public health system because we want to give the best to our patients, right? And so, and especially so in teaching hospital, where we're supposed to be at the cutting edge of healthcare provision, and yet because of underinvestment, we cannot provide that cutting edge medicine that we know about, that we train in, that we, you know, speak to our colleagues about. UMMC, supposedly one of the leading teaching hospitals, still doesn't have a robot, for instance. I mean, it's not the be-all and end-all, but I'm just giving you an example of the kinds of frustrations that my colleagues and I face. And so you add on the pay disparity, and you get, you know, multiple things, and it doesn't take much for people to snap or straw that breaks the camel's back to get people to get up and leave.
Thank you, Prof. Adeeba. Allow me to pivot a little bit to hear Dr. Kumar's thoughts. Dr. Kumar, you mentioned in some of your remarks earlier that there will be ways for us to get the private sector involved, for example, through a capitation payment using global budgets and a focus on primary healthcare, and obviously through clinical audits as well. In your view, Dr. Kumar, how can we apply some social market principles, trying to address some of the market failures that you spoke on and Dr. Prof. Williams spoke about as well? How can we reform the health financing system so that the incentives are aligned so that we don't have market failures?
I think that's quite difficult, I think, to not have market failures, you know. I mean, this whole issue of, you know, healthcare is, Professor Williams talked about information asymmetry. So the patient really will never know whether or not the treatment is what is really required, whether you need the scope or whether you need the angiogram. So there's a problem there. So when you link fee for service, and then money then becomes an issue that affects clinical judgment. You have problems. Very difficult to solve that. But coming back to the issue of GPs, see, we have 7,000 GPs in the country, and our treatment of diabetes and hypertension, ischemic heart disease isn't quite optimal, and that's because a lot of our patients just go shopping around. They go and you don't have a fixed physician looking after them, and if they default or whatever, people don't look into the whole issue of their weight, of their exercise, or how much they're monitoring themselves. So we could have a system like in the UK where the national, our government system allocates patients to GPs who are interested in looking after such patients and pays for these patients. And these patients get the treatment at the GP without paying anything, just like as they get from the outpatient department. And the benefit is that they just see one doctor, because in the outpatient department, in a busy outpatient department, you can go in and see different doctors at different times. And the doctor who saw you the last time is not going to see you this time, there's no continuity. So it's better to see a GP, and then the GP, then there can be SOPs, protocols, GP follows, you check the eyes every 1 year, you check for this, you check for that, you check the HbA1c for diabetics. So these kind of things can actually improve the management of our NCDs. But it means a budgetary allocation, because it means the GPs have got to be paid some kind of capitation fee for all these patients. That's one way in which it can work. The other thing I think we got to do about the private sector is to to prevent it from expanding further. I think it will be unfair, it will be unethical really to nationalize them because they put money into it and all that. So let the private hospitals that exist remain. But I think expanding private hospitals actually aggravates the brain drain problem. When you open up new private hospitals, you do more medical tourism and all that, health tourism, more doctors leave. So I think that we have something we can do. So I think we should do that. Intervene, don't allow, for the time being, don't allow expansion of the private sector. Allow the existing private sector, and they'll be quite happy. They'll be quite happy to have what they have, but don't allow expansion. I think that's something I think we should consider very seriously.
Thank you, Dr. Kumar. Allow me to ask a follow-up based on a question from Muhammad Anis, and I would love to hear Prof. Williams' thought about this question as well. And I'll quote some parts of Muhammad Anis's question. It was sent at 12 p.m. today, so you can read in the chat group. He agrees with you in regards to market failures in the health sector, as well as increasing public financing. And a huge proportion of Malaysia's health spending is out of pocket. As much as 40% of Malaysia's health spending is out of pocket. So on one hand, it gives choice to the consumer, allows them to pick and choose which provider they prefer, which is an important element in a health system. But on the other hand, it's very inefficient because we're not pooling it, and we're not risk sharing, and we're not maybe even increasing solidarity. Dr. Kumar and then Prof. Williams, how might we optimize the 40% out-of-pocket payments in Malaysia and make it prepayment without compromising choice? So in a sense, it's a balance between choice and efficiency. What are your thoughts, Dr. Kumar, and then to Dr. Williams?
You see, Dr. Khor, the out-of-pocket payment, I think you divide them up into two parts. One is what people pay when they just drop in on the local GP, and they do it because of convenience. They can go after office hours, they can go anytime, and or they just go to the pharmacies and buy some medicine. And that actually isn't very onerous on them. But they really can't do it. They can go to the outpatient department and wait and get the medicine. But this is something that is not really causing much harm to our population, because they can do something else they really want to. It's more for convenience. They do it. Now, where we got to look out, where the problems are, is we're talking about catastrophic expenses, where you have, let's say, a person with chest pain and he's told by Siput hospital, we think it's heart, and it comes, but the appointment to see a cardiologist in Ipoh GH is 2 months or 3 months down the line, doesn't get a date. And he sees the cardiologist says, well, you need something, but we are busy now, and in 2 months maybe we'll try and call you. But that is when people are forced to go to the private side because they are afraid by waiting for the government. The government's going to give you the treatment anyway. They will give you, they won't turn you away. But in cases like cancer, for example, surgeon says, okay, I need to do surgery as soon as possible. I got to get a CT scan, thorax abdomen done. CT scan, thorax abdomen takes a month and a half. On the day you go, the machine is broken down, takes another month after that. I mean, that's the kind of thing that then drives patients to beg and borrow and go to the private because there's no choice. It's more the catastrophic expenses that I think we should be concerned about, because going to the GPs and spending to the GPs, I think that's a choice. And the GPs can't really charge too much because there are government clinics all over the place, so the GP charges too much, they won't get clientele. That is not really breaking people's budget. But it's a catastrophic expenses when a person, a loved one in the family has got a serious illness, you can't get to see the specialist, or seeing the specialist waiting for results, and results, I mean, the investigation takes a long time. That's when people go. Now, we can do something about that. Whether we can have some kind of fund, or a government fund, that partially pays for this kind of things, that pays for example, CT scan, doing a CT scan outside, that the government can negotiate with the private sector and get it done, But I think to have a different insurance, the problem like I talked earlier, 20% of our families earn less than $3,000 a month. This is a household income. Another 20% earn between 3,000 and 4,003. So, I mean, if you open up to voluntary insurance, then you are again going to cater for the richer people. The richer people will have money and they can take the insurance, they can go. You cannot do it that way. If you do it that way, what Tudor Hart said, so, it is the poorer people who will be marginalized further by marketization. If you marketize the system, let's say you provide, okay, those who want to take insurance, take that, then at least you're covered. Yes, but then when you're covered, they go to the private side. Because they go to the private side, more government specialists will go to the private side because the market is there. So I don't think you can go for a partial solution like that. I think Mahathir did us a big disservice by allowing private for-profit hospitals. But that cat is out of the bag. We can't put it back into the bag. But to try and solve it by even further marketization, attempts is actually the wrong way to go. And I think what Tudor Hart said, I think is very, very true. The more you marketize, the bottom 40%, the bottom 20% are going to get even more marginalized. There's no way out of that. Thank you.
Thank you, Dr. Kumar. Your thoughts about, shall we say, the neoliberal march and privatization of public services, not just healthcare, I think it's a very compelling one. Prof. Williams, if we can turn to you, please. Your thoughts about how can we shift the post-payment, shall we say, the 40% out-of-pocket to pre-payment? How might such a model look like in Malaysia? Over to you, Prof. Williams.
Well, based on the basic data, the stylized data that I showed you just now, you could double the expenditure, or you could double the resources available for the public system simply by charging a fee of 2.50 ringgit per day per person. Because that is the amount that is already being spent on the private sector. And if you were to introduce, for example, an insurance scheme based on a payment equivalent to 2.50 ringgit per person per day, or actually much, if this is a compulsory scheme is not an insurance scheme anymore, it's a tax. But basically, if you were to impose a tax, or however you want to call it, the equivalent of less than the price of half a cup of teh tarik per person per day, then you can double the resources available in the health service and the public service, I mean. And so the issues that Adeeba and Michael have been talking about, which are true, I mean, they are clear. They are questions of lack of resources. And that can be solved by introducing a payment of that amount, a very small amount, in order to, which is already being paid. Now, of course, there will be some families that still, that would be a challenge, of course. Well, then you can provide exclusion for them and you could provide some form of progressivity in it, so people who are very poor would not pay anything, and people who are very wealthy would pay more. You can find that. There's no problem in doing that. Now, the issue of choice, to me, is a red herring. I do not believe that you have anywhere near the same sort of choice in private health as people are claiming. First, because of the issue of asymmetric information. I agree, if you go to your local GP, yes, your local GP who you see regularly and your family go and you build a relationship with that. That is an extremely valuable relationship with a doctor that can, in my opinion, be carried out very effectively through the private sector, because there is a repeated interaction with yourself and your family members and your community members. So there's a social regulation of the behavior of the doctor there. But if you go to a large private hospital, you have no choice, really. I mean, you register with an illness, and then they will say, we have this consultant, and then you go to see that consultant. And if you don't want to see that consultant, of course, you would, generally speaking, have no reason not to go to the consultant that they are credentializing and that they are recommending to you. The only choice you have is to leave that hospital and go to another private hospital. So you have a transaction cost, you have a travel cost, and that's the nature of the choice. Now, the problem with that choice issue for patients is, once you are sitting in front of that consultant in the private hospital, you've already been captured in terms of the information asymmetry, because then that private consultant is then telling you, oh, I'm sorry, you have this condition, and this condition can only be treated in this way. Oh, and by the way, it's going to cost you this amount of money, but don't worry, because it's going to be paid for by your insurance. And if you have that, then your choice is gone, suddenly. So I think that this idea that you get great choice in the private sector is a myth, because choice depends upon information. And consumers of healthcare don't have that information. And they are particularly vulnerable, particularly because they're going there and they're ill, or they're bringing a loved one, family member, and they want treatment quickly, or they have a long-term chronic condition which they can't get treated successfully in the public sector, and this can have physical problems, long-term medical issues, psychological issues, social issues as well. And so they are vulnerable to this type of moral hazard that is the doctor overprescribing, and the choice element there is gone, unfortunately. That's why you need to have a separate regulatory system, because the market itself doesn't provide the regulatory system. And the failure in Malaysia, unfortunately, is the governance system, the regulatory system, is such that the behavioral attitude of people in the MMC is the doctor knows best, you listen to the doctor, you always take the doctor's side, and you do nothing for the patients. And that's why it fails.
Thank you, Prof. Williams. So I guess paternalism is alive and well in the healthcare and medical industries, and it's something for us to work through. Allow me to have a brief summary of where we are today and ask the panelists an open question for any one of the three or all three to share their thoughts. All three panelists appear to agree that there is a role for the private sector in Malaysia's healthcare, and the role needs to be carefully calibrated, carefully circumscribed, and carefully regulated as well. So all three panelists also agree that there's probably an importance to the private sector that we cannot ignore. Funding-wise, the talent-wise, human capital-wise, the resources and facilities-wise, there's a significant presence of the private sector in Malaysia, which is not easily ignored. Therefore, my final closing question for everyone, just sort of summarizing the trends of the conversation and also the questions that are coming in. I'm sorry, everyone, my personal responsibility for not being able to answer every question that you've asked, but allow me to ask this one as a summary question to all three panelists. Anyone is free to speak. How do we govern the public and private sector in Malaysia in a way that can achieve equity, efficiency, as well as good high quality outcomes? The question is about governance, and you may require conversations about the Ministry of Health, outside the Ministry of Health, like the Malaysian Medical Council, maybe Bank Negara, Economic Planning Unit, and so on. So let's make it as open as possible. How do we govern the health system of Malaysia to have the public and private sector as integrated and as harmonious as possible to achieve equity, efficiency, and good quality outcomes? Any of the three panelists, the floor is yours.
Well, I would say from a management perspective, we understand how these things must be done. And the primary foundation of any good governance system is diverse stakeholder inclusion. The problem is that under the current system, the regulation is in different places. The regulation of health insurance is with Bank Negara. The regulation of doctors' ethical practices is with MMC. The regulation of the payments under Schedule 13 of the Medical Act is under CCAPS in the Health Ministry. They're under different organizations. But so first, you need to get it into one single place. Secondly, all of these regulatory systems, apart from the insurance part, which is under Bank Negara, all of the other regulatory systems are handled by doctors, medical practitioners. I mean, I'm also a doctor. I mean, medical practitioners. And there isn't sufficient inclusion of patient representatives, for example, community representatives, for example. Michael mentioned, and Adeeba also mentioned, the frontliners in the lower tiers who are actively engaged in the process of delivering healthcare face-to-face with patients, but they don't appear in these governance bodies. You know, housemen don't appear in these government bodies. Junior doctors don't appear in these governing bodies. And so what you see is too little diversity in the stakeholder groups in terms of the governance process. And the basic principle of effective management is that you have as diverse a group of stakeholders involved in the management and governance system. And that has to change.
Yeah, if I can jump in there, I mean, just as an example of the lack of diversity, and probably it represents a conflict of interest, actually. And this is by no means a criticism of the person, but it's just the office and the way it's been set up. The president of the Malaysian Medical Council is the Director General of Health. The chair of the nursing board is the Director General of Health. The chair of the midwifery board, I think, and of pharmacy board, and the list pharmacy board is also the Director General of Health. So, you know, there's A, lack of diversity, and B, multiple conflicts of interest there. And the other aspect is in terms of governance. I think often the Ministry of Health sees itself as, you know, being responsible, and we see this, we feel this, and we see this during this COVID pandemic, as being responsible for Ministry of Health personnel and Ministry of Health facilities, whereas it should really have a bigger and broader view of being, you know, the oversight for healthcare providers. So there's that tension as well that translates into all kinds of barriers at service delivery end.
Thank you, Prof. Adeeba. Dr. Kumar, if you have any final thoughts.
Thanks, Dr. Khor. I think in addition to institutional changes, I think it's public pressure, public expectations. I mean, like you said earlier, you know, that healthcare is a barometer, you know, the level of healthcare is a barometer of how fair a country is or how inclusive a country is. I agree with you totally on that. I mean, if you want to build a harmonious nation where people feel they are cared for, they're part of it, I think healthcare builds social solidarity. And so I think it's also the role of people to speak up. If they feel that themselves, their families, or anyone they know is not getting the proper care, they should speak up, and the media should speak up. We just can't leave it to the institutions. Sometimes they get a bit ossified. You know, it's got to come from the bottom, and we've got to say that we are a middle or high middle income country, and we should be able to put a bit more of money aside for healthcare. And we should make sure that the people in the bottom part of our population get the healthcare they need. I think these are important things that we all should demand. It's not just the job of the MOH or even doctors or even institutions. I think we all should say our fellow Malaysian citizens, and even the refugees, you know, not even the Malaysian citizens, but people in this country should get decent care. And that's the basis of solidarity, and there are a lot of externalities. If people can feel positive about the society, they feel positive that they're cared for, that society cares for them, I think it cuts down a lot of, delinquent kind of tendencies and, even depression, mental illness now. There's a lot of what they call externalities. You do this kind of thing, you have a more caring, more comprehensive healthcare system. It will make us all not only healthier, but happier and more harmonious. So I think it's something that we all need to work towards. Thank you.
Thank you, Dr. Kumar. As a brief summary, Prof. Williams mentions the need to centralize the fragmented landscape of regulators. Prof. Adeeba mentioned the need to remove all sorts of conflicts of interest if you're trying to regulate, because you can't regulate yourself. And Dr. Kumar has indicated the importance of mobilizing society, the public, the media, and citizens in order to try to claim what should be really a human right. Thank you very much, ladies and gentlemen, for attending this webinar with Konrad-Adenauer-Stiftung together with us for the last couple of hours. It's been a pleasure to moderate this session and also to listen to the thoughts of our three expert panelists. Allow me to pass the floor back to Chen. Chen will take us through the closing. Chen, over to you.
Thank you, Dr. Khor. Thank you to all the speakers. It has been wonderful to hear all your ideas. So many things that we need to look at in the future, because this is just the starting for further dialogues and further exchange of ideas. And to give us your ideas, also thank you for your questions. And we have a webinar feedback form that we would like you to also tell us more of your ideas. You can find the feedback form in the chat right now. If you are tuning in from Futures Malaysia Facebook or on Futures Malaysia YouTube site, you should be able to find the link there as well. So we'll be very grateful if you could fill in that form. It's only a few questions, takes a few seconds for you to fill in. And so to end, I would like to invite Professor Dr. Aslam Hanif to give the closing remarks.
Thank you very much, Chen. I think a lot of whatever I wanted to say, I think has been covered. There's no time for any summary points. I just want to maybe on behalf of Futures Malaysia, just to say that, we're a newly established NGO. The idea was we wanted to participate in building a future for Malaysia. And the idea of this series is to get people who have all kinds of ideas and backgrounds, bring them together, exchange ideas. We did try to get somebody from the private medical practitioners, but I don't think they could, they were not able to make the session today. So our idea is to actually get varying opinions, even if they were, contradictory and so on, so that we can actually try to build some kind of consensus as we move forward. So that's the idea of Futures Malaysia, talking about maybe trying to get a consensus on that preferred future that we would like to have for Malaysia moving forward. We are going to have more webinars. The next one will be, we are hoping it to be in early June, and it will be on an economics topic, something on GLCs and the need for maybe reforms, and of course it's all part of this social market economy perspective series, and for that reason I think it's important for us to keep in mind, while we did say that we need the market, but when we say market, there are so many types of markets around, and personally I think many of us feel that the social market has got something that we can learn from, rather than maybe what people would call liberal markets and overly private sector dominated systems. So somewhere along the line of the social market perspective. So with those few words, I thank Dr. Khor, your excellent moderating of the session. It was great. Thank you to all the speakers, and thank you to Chen, and I pass it back to Chen.
Thank you for coming. So we have reached the end of the webinar. We look forward to have the next one, and maybe you would like to join us too. Thank you. Goodbye. Have a nice day.